I am still in clinic and just finishing what round.
Okay.
Maybe you can start lah because I only observe kan and then I give comment later.
Okay, Doctor. Can.
Right.
Okay, let's start this morning session with Sabu Matani Al-Fatihah. Assalamualaikum warahmatullahi wabarakatuh and a very good morning I bid to our supervisor and mentor Dr. Taufiq and to all my group mates. So insyaAllah this morning we would like to present several procedures. So to start with, I will be presenting my part first which is venipuncture. Okay, my name is Wan Hamiriza bin Abdul Hamid. Next. So here is the outline for my presentation. But before I proceed, I would like to briefly explain about venipuncture. So venipuncture, or the other name is phlebotomy, is a process or intervention which involving obtaining intravenous access and taking blood from patient vein, mainly for the purpose of blood sampling. Okay, next. So the first part is indication. As I mentioned before, the main purpose for venipuncture is taking blood for blood sampling, which involve to assess the blood components such as hemoglobin, white blood cell, platelet from the full blood count, and also sugar level, coagulation factor, and also lipid profile. Apart from that, from venipuncture, actually we can assess several organ functions such as kidney from the renal function test, liver from liver function test, and also thyroid from thyroid function test. Plus, we can assess the electrolyte in our body from the serum electrolyte. Apart from that, venipuncture is also useful for diagnostic purpose. For example, if we suspect that our patient had neoplasm, we can order for tumor marker. For example, we can order for alpha fetoprotein in patient with hepatocellular carcinoma, or in several other cases like myocardial infarction, we can order for cardiac enzyme. And yes, apart from that, we can also order for blood culture and sensitivity to screen for any infection. Apart from these four, the other indication for venipuncture is for cross-matching purpose prior to blood transfusion in order to determine whether the donor's blood is compatible or not with the recipient's blood. Okay, next. Then proceed with the contraindication in venipuncture. In what condition that this patient have that will cause venipuncture should not be done at that particular site. First is in the presence of infection such as cellulitis or abscess at the particular site or bleeding. So that particular site must be avoided for venipuncture. Apart from that, if recently there was venipuncture done at that particular site, so the next venipuncture must be done at the other location. For example, another arm. Apart from that, if there is any vascular access device such as IV cannulation at that particular site, so that particular site must be avoided from being injected. Apart from this four, the other contraindication for that particular site for venipuncture is presence of any vascular shunt, graft or fistula, or even in the presence of venous scarring, which can be determined by firm, thickened and tended vein. Last but not least, if our patient had undergone mastectomy, the arm on the side of mastectomy must be avoided from being venipunctured, because I found that there is a risk of this patient to develop secondary lymphedema in the extremity if the lymph node is removed together during the mastectomy. Okay, next. So here is several equipment that must be prepared for venipuncture, and I am pretty sure that all of us are already familiar with all this equipment. But I would like to stress here is about blood sampling bottle, like shown in the picture. So this blood sampling bottle comes with purple cap. Actually, for different colors of blood sampling bottle carry different purpose. For example, for purple cap is useful for taking food blood count, and then for yellow or gold cap is used for renal function test, liver function test, inflammatory markers such as CRP. For grey cap is for monitoring blood sugar level, either is random or fasting blood glucose, and also lactate. For blue cap is for coagulation profile, INR, and also D-dimer. Meanwhile, for pink cap is merely for cross matching. Okay, next. Then proceed with the technique for venipuncture, but please bear in mind, for every procedure, it's actually share the same basic concept, in which in the beginning of the procedure, we should introduce ourselves, confirm patient details such as name and age and registration number, briefly explain about the procedure to the patient, and most important is asking for patient consent. So for the technique of appropriate and proper venipuncture, it involving introduction, preparing all the equipment, choosing arm and vein for injection, and also injection of the needle. But I'm sure that you will be tired and bored of listening to my babbling and explanation. Therefore, I provide a video for you guys to appreciate about the technique for venipuncture. So please enjoy the video.
I don't know, I'm actually one of the final year medical students.
So as I mentioned before, for every procedure, please start with introduce ourselves, confirm patient detail, briefly explain about the procedure, and asking for patient consent.
Involving small needle, inserting it to one of might be a touch uncomfortable. Are you allergic to anything? That way.
So here is the several equipment that must be prepared for venipuncture. Please take note for the angle of insertion of the needle, 30 degrees. And for every procedure, don't forget to thank patient as sign of appreciation and respect to the patient, and also to the blood that they had sacrificed. And then don't forget to label the specimen to avoid exchange with other patient specimen. Okay. Next. Okay, so that's how the appropriate technique or proper technique to conduct venipuncture. So from the video, the doctor just now show how to choose an appropriate vein to be injected to collect the blood. So the most commonly used vein is the median cubital vein, in which it is located at the cubital fossa, and actually this vein serve as an anastomosis between two veins, which is cephalic and basilic vein. Apart from medial cubital vein, there are several other veins that can be used but not preferred, such as cephalic vein, because this vein tends to roll, and also basilic vein, because this basilic vein is very close to brachial artery and also brachial nerve. And both of these vein, cephalic and basilic vein, can be found in the forearm and also in the arm. In case that the patient's arm vein can be found or located, so we are going to use the wrist or hand vein to take the blood. Okay, next. So here is some complication from venipuncture. I'm pretty sure that if some people or even doctor ask us about complication of venipuncture, suddenly somehow we tend to forget and hesitated to answer their question. So here is the tip that I would like to share. So this is the mnemonic for the complication of the venipuncture, which is bad tip that include bleeding, bruising, arterial puncture, damage to the adjacent tissue, thrombosis, infection, and pain. So for the complication of the venipuncture, it can be divided into two. Either is immediate complication, which is bleeding, arterial puncture, damage to adjacent tissue, and also pain, and also late complications such as thrombosis. Okay, next. Before I finish my presentation, here is several questions that we can answer it together. So let's go through it quickly. So first, which of the following is not an indication for venipuncture? So the answer is obviously D, because in venipuncture, we take blood from the vein, not the artery. Okay, second. So blood sampling bottle, which one is true? So this should test our memory a little bit, but the answer is C, blue cap, because blue cap is merely for coagulation profile. Last but not least, which one is not a complication of venipuncture? So for the complication, remember the mnemonic that I shared to you, which is bad tip. So for this question, I think this all is the complication of the venipuncture. So the answer is none of the above. Okay, that's all from me. So here is my references.
Okay, Hami. After this, ada yang ini tak? Ada student ada yang present mana? Oh ya, Hidayatul is
Ada prosedur lain.
yang blood CNS ada?
Blood CNS,
Anyone? Other student? Tak ada? Ada tak?
Ada. Chair number 4.
Okay lah. So nanti kita discuss lah what's the difference between venipuncture blood CNS tu nanti ya. And as well as yang IV cannulation yang after this kan yang Hidayatul ni. Nanti kita tengok apa beza different detail in teknik ada some difference ya. Okay. Balik yang Hamid tadi yang Q tu tadi balik question 2. Ni correct. So yang A tu pakai apa? RFT, LFT.
okay, sorry. Yang RFT and LFT tu yellow, doktor. Yellow or gold cap.
MBC apa?
BC purple.
Okay, and then cross matching.
Pink.
Cross match pink ya? Betul ya?
Cross matching pink.
Okay, and then random.
Grey.
Okay. FBP kalau full blood picture pakai yang apa?
Pink juga kan? Purple.
Purple lah. And then last yang common tu tadi TFT dah. Iron study or apa nama? HB analysis. Satu-satu. Iron study pakai apa?
Iron study. Yellow code.
Okay. Sama Principally yang yellow tu yang untuk biochemical
Biochemical.
parameters ya, biochemistry. Dan yang purple tu untuk hematologic. So, lagi satu tu HB analysis ya. Kalau patient-patient thalassemia kan kita hantar HB analysis kan. So you pakai apa?
Purple.
Purple lah untuk hematologi ya. Alright. So itulah. Okay, so alright, thanks. Continue yang IV cannulation, second presenter.
Assalamualaikum warahmatullahi. My name is Hidayatul Alia binti Sobri. Today I will present intravenous cannulation procedure. Okay, so before that we have to know what is the indications and the contraindications for IV cannulation procedure. For the indications are including repeated blood sampling, IV fluid administration for resuscitation, IV medication, IV chemotherapy for cancer patient, IV nutritional support like total parent TPN, total parenteral nutrition, IV blood or blood products administration, and IV administration for radiologic contrast agent such as CT, MRI or nuclear imaging. So what are the contraindication for the IV cannulation? The contraindication are extremities with broken bone and traumatic injury. And next, we have to avoid in patient that have to inject at the patient that have compartment syndrome. Compartment syndrome is a painful condition that occurs when the pressure within the muscle build up at the dangerous level that cause the decrease in blood flow, oxygen, and also nutrition to the muscle. So we have to avoid patient with compartment syndrome, and then we have to avoid in extremities that is swelling or edema, and also avoid the site of previous infiltrates on previous extremities. Infiltrates means that when the fluid leaks out of the vein into the surrounding tissue, and also we have to avoid open wound or broken skin. So next slide. So before the procedure, what we have to do, like Hami said just now, we have to introduce yourself, and then confirm the patient's name and date of birth, and then briefly explain the procedure, gain consent, check if the patient has any allergic such as latex. So we have to avoid the medical equipments that made of latex such as IV catheters from latex, and then adequately expose the patient's arm for the procedure, position the patient so that they are sitting comfortably, ask the patient if they have any pain before the procedure, and wash hands by alcohol gel. So next slide. So what are the equipment that we need to perform IV cannulation? So before that, we have to prepare the clean tray. So we gather the equipment, which are the intravenous catheters. Usually in the pediatric, we use around 22 gauge to 24 gauge for the pediatric, and the size depend on the age of the patient, the condition of the patient, and also what the primary use of the IV. And then 2 times 2 gauss chloroprep. This is optional. It is used to promote aseptic technique to reduce risk of the direct contact with the patient, and it is to wipe the chlorhexidine for aseptic technique, and then tegadem. And next, it actually the second picture is not intravenous catheter, but it is we call it as T connector. And the next picture is a positive pressure cap, tourniquet, clean glove, saline flush, arm wide, tape, hand sanitizer, or soap and water, and also alcohol swab. And next slide. So this is the basic part of an IV catheter or cannula, which consists of the needle, catheter, hub wings, the yellow colored flashback chamber, needle grip, and also the safety needle cover. Next slide. So for the technique, before that, next slide. So before we start, we have to alcohol. We have to rub our hand with the alcohol, or else and also we can use the glove. And then we open the gauze and alcohol pack, and then open the T connector. After open the T connector, prepare for the saline flush, and next slide, and then attach the saline flush to the positive pressure cap, and then after attach the saline flush to the positive pressure cap, and then flush the saline through the cap and the T connector, and to ensure that and ensure all the air is removed. And next, after prepare the saline flush, open the open the tegedem, and then prepare the tape, and then wash your hand again with the alcohol. And next slide, wear the glove, and then next is to place the vein. So for the intravenous cannulation, there are many sites that we can access, such as dorsal venous plexus on the dorsal venous plexus on hand, cephalic vein on the radial border of wrist, and also on the foot at the dorsal venous plexus, and also like in this picture at the cephalic or cubital vein in the anterior cubital fossa, and also we can do on the scalp, which is at the superficial temporal vein. Usually at the scalp, we do when it is difficult to access the peripheral extremities for intravenous cannulation. And next, for find the vein, we can find through the visualization or palpation. We need to tap it or ask the patient to fist their hand and then apply the tourniquet. After apply the tourniquet, and then prepare the skin with the cleansing pad and gauze. Use the alcohol swab for 30 minutes, 30 seconds, and let it dry for 30 seconds. Next slide. And after that, open the cannula, remove the plastic that covering the cannula, and then hold the cannula with the needle bevel up, as you can see in the picture. I'm sorry, the number is number dia tak betul sikit. And as you can see, the needle is the hole is facing up, and then insert the needle bevel up at the 25 to 30 degree slowly, and then wash. Is there any flashback of the blood, the backflow of the blood? The backflow of the blood. When you see the backflow of blood, it is indication that your needle is inserting into the vessel. And then advance slowly the catheter and decrease the angle more parallel to the skin, and then there will be more blood flashback. And then next slide. So once you advance the catheter off up until into the introducing needle, so simultaneously we withdraw the needle from the catheter, and then we remove the tourniquet, and after that we apply the pressure on the insertion site before we remove the needle to avoid the blood leakage onto the skin, and remove the needle carefully. After that, we attach the T connector to the cannula and flush the saline to look for any infiltration, sign of any infiltration. I will explain the sign of infiltration in the next slide on complication. Next slide. After that, we have to secure the IV by apply the tegedem, and also next we clamp the T connector, and lastly we secure the catheter with tape by using the chevron technique, CHEVRON, chevron technique. So we have to avoid to cover the insertion site with any opaque cover. So because we want to see the insertion site to look for any sign of phlebitis after this. So also we should not cover the insertion site with the tape, because also we want to see the sign of phlebitis or infiltration. Next slide. So, and this is we also for the pediatric, we can use the supporting device such as the board to prevent from the patient to bend their extremities. Also, we can use protective device to avoid accidental remove of the intravenous catheter. Next slide. I want to show in this video the chevron technique for the tape. Can you play at the minute 10:80?
With tape using the chevron technique. This is shown here by taking a half-inch piece of tape, adhesive side up, sliding it under the hub of the catheter, and cross the tabs over one another, adhering them to the patient on opposite sides. When necessary, use a second piece of tape and secure the attachment device. When an IV is placed over a joint, use
So you can see that is the chevron technique. We used to
device can also be placed over the IV to avoid accidental removal.
This is the protective equipment. Next slide.
To allow for hourly assessment of the site.
So from the video you can see that the tape is across on one another. So we call it as chevron technique. So after the procedure, explain to the patient that the procedure is now complete and they should sit the review if the cannulation site become painful or inflamed. Thank the patient for the time. Dispose your glove and equipment into an appropriate clinical waste bin. Wash your hand and document the detail of the procedure, such as the location of the IV cannulation, such as dorsum of the left hand, the size of the IV cannulation that we use, and the number of attempt that we done, and then the flow and the patency. Is there any complication? Is there any sign of the phlebitis or infiltration? And also the time, the vital sign, and the name of the patient, and the indication that used for the cannulation, and also the date that we put the IV cannulation. Next slide. So what are the complication that can complication be during the procedure and also after the procedure? So the complication are include pain, failure to access the vein, blood stop flowing into the flashback chamber, difficulty advancing the catheter over the needle and into the vein, difficulty flushing after the catheter was placed in a vein, arterial puncture, thrombophlebitis, peripheral nerve palsy when the nerve is injured, compartment syndrome, and also skin and soft tissue necrosis. Next slide. So this is the complication from the IV cannulation, which is the infiltration. Infiltration, as I said just now, it is the leakage of the fluid from the vein into the surrounding tissue. So the signs are swelling, blanching at the IV site, cool temperature at IV site, no blood return, and you will feel difficulty to flush. And next complication is phlebitis, which is due to the medication or fluid that we inserted. It caused the inflammation at the vessel. So the signs include red streak along the vein. Vein feels like a hard cut, redness at IV site, and also hot skin temperature. I think that's all for my part. Thank you.
Okay, any questions? Tak ada. So, any difference between tadi IV line insertion dengan apa nama tadi? Vein puncture, Hidayatul?
Different
In the technique.
in the for the technique. For the venipuncture, we don't have to put the tegaderm. For the IV cannulation, we put the tegaderm and we maintain the cannula.
Tadi insertion teknik sama ke beza?
For the technique, I think same. Not same.
More or less. Yeah,
More or
so
less.
but only different apa nama dia? Equipment je, device. Kalau vein puncture kan biasa kita pakai yang tadi wing needle kan, yang Hamiriza punya video tadi. Kalau IV line ya of course we use bermula tadi kan, IV line catheter size tuan yang tadi besar kan, ada kan. Color apa tadi?
Color biru. Blue.
Biru tu berapa size?
Hero 2022.
Betul, betul, Yang ini 24 berapa? Color apa?
Yellow.
Biasa kita pakai kalau paste itu yang less than 5 years kita pakai yellow dulu. Biru itu kalau udah school age. Tapi kalau for apa nama? Blood ini nak ambil donor tuh nak ambil apa? Ya transfusion juga lah. Kita pakai yang lebih besar, size 18 mesti, or 20 lah. Color apa? Yang lain?
Lain. Pink.
Size berapa yang pink tuh? Kita cari. Just googling aja ada Google punya image pun ada. Okay. Alright. Let's say we need IV line and blood sampling. So you will prick twice or once?
Twice.
Kok kali? Kasihan.
IV line.
Kalau
one.
kalau children tadi kan in your video senyap aja patient. Kalau in children teriak-teriak lah semua patient nangis. Even though yang kooperatif pun still menangis, crying. What more yang non kooperatif patient. So usually we minimize the number of puncture lah, of pricking sekali je. And then using balona tuh boleh tak? Tadi kan if you press the di catheter dia akan berhenti darah. But if you let the catheter the blood flows, so we can collect the blood from there. Dropping lah from the bukan tip lah yang belakang from the end of the balloon just dropping collect blood sampling tube. Oke ya, yang lain paham ya? Boleh aja sekali pakai IV line. Saya lagi suka ya malas pakai wing needle tuh. Selalu pakai IV line-nya sekali. Collecting blood dengan giving IV fluid. Ya.
Okay.
So you all still at home kan?
Yes.
Biar one week lah. Nanti baik to go back to Kuantan ya. Oke. Number 3 siapa?
Saya. Assalamualaikum warahmatullahi wabarakatuh. Can you hear my voice? Yes.
Okay. I will proceed our presentations by presenting this about the central line. So my presentations including of indication, contraindications, recommended common site preparations, and also the technique can be used in central line, and also the complications and how to prevent the complication. So we start with the indications. So basically for the central line, because we use large veins, and then it is indicated for the delivery large volumes of solutions. For example, we use blood products, drugs, and TPNs, and also chemotherapy. Because of it has immediate access, whereby can be used as soon as possible after we place it. So it is a good choice for urgent or emergency resuscitations, and also for hemodialysis. It also good for monitoring central pressure. For example, if we want to estimate the right arterial pressure. So because of that, we can use to assess the cardiac preload and volume status in critical inpatient, and also assess and also it's also can assist us to diagnosis of right heart failure and guide the fluid resuscitation. And bear in your mind that apart from the indications, we must also thinking of the contraindication for this procedure. So the contraindication is infections or burn at the site at the area that we want to introduce the central line, because it will can increase the chance for spreadings of the microorganism, and also any occlusions of the vessel, for example, thrombosis, obstructions by the mass or tumor, and also any abnormality of the vessel and coagulopathy. So next, we proceed to the recommended location. So I just put three common recommended locations, which first is IV, in IJV, internal jugular veins. So internal jugular vein, it is located at the carotid sheaths, whereby it is lateral to the carotid artery and between two head of uh, sternocleidomastoid. And then bear on your mind also that on the carotid sheaths, there is also carotid artery. So we must need have a basic knowledge how to differentiate between the internal jugular veins and also carotid artery, because we want the vein one. So basically, uh, how to differentiate it? Can I ask someone to explain how to differentiate between the jugular veins and the carotid artery? I open the questions to all of you. Tak ada. Okay, Hami, how to differentiate between the jugular veins and the carotid artery?
For jugular vein, is visible but not palpable.
Yes.
And then internal jugular vein has dual wave.
Good. Okay, good. Very good. Okay, next we proceed to the another side is femoral vein. So femoral veins, it is deep to the medial thirds of the inguinal ligaments, and also the third is subclavian vein. So, for proceeds the procedure, we must set up the preparations. So firstly, the preparation start with the medication practitioner. So in order to decrease the significance of infection complications, so the medical practitioner should go on sterile fashions with sterile gown, glove, cap, and mask. And also we prepare the equipments for this central line procedure. For example, is the guide wire, scalpel, gauze, dressing, sterile drag, towel, sutures, dilators, and then needle, and also lidocaine for anesthetic. And then we start the step by cleaning. We start the procedure after already the preparation is ready. So we start the step by clean the area and apply the sterile film, and then apply the sterile sheath. Uh, and also this procedure, we use ultrasound guide uh, in order to make easy for us to define the anatomy. And then before we use the ultrasounds, we apply the sterile sheath and then confirm the anatomy. So at the anatomy, to use the ultrasound, we must have the knowledge how to differentiate between the artery and the vein. So basically, on the ultrasound, artery is pulsatile, and then vein, when we compress the ultrasound probes, and then the vein is collapsed due to collapse when we compress, because vein is not non-muscular bone. And then under the ultrasound guidance, we insert the lignocaines cutaneously. Okay, basically there is a technique to insert the central line that have been used frequently, which is Seldinger techniques. So basically, in this Seldinger technique, first under ultrasounds, we insert the needle that attached to the shrink, and then we insert to the vein. When there is a flashbacks of the blood, it means that it's indicate that there is the needle have reached the veins. And then after that, when the blood is freely aspirated, and then we can remove the shrink, and then immediately we insert the syringe wire. We insert the wire, and then this wire we keeping holding the wire. We keeping holding the wire, and then we slowly remove the needle, and then we must ensure that wire stay in the vein, still in the vein, and then we use the scalpel to make an incision, small incisions, to pass the dilator, or to pass the dilator, to dilate the incisions in order to pass the dilator, and then after that we put the dilator to increase the to make the to dilate to dilate the tract, this tract, the dilator, and then to dilate this tract, and then after this tract is enough dilate to pass the central catheter, and then we put the central catheter. At this moment, the gauze wire is still, the guide wire is still at the venous, and then after we insert the the central catheter, and then slowly we remove the wire, the guide wire. After that, we aspirate, and then clamp, and also suture, and apply the dressing. So after apply the dressings, we if we do for the central, we do at the internal jugular vein, we can obtain the X-ray to assess, chest X-ray to assess the proper placements, and also to assess any complications such as hematothorax and pneumothorax. So for this, after that, I will present about the complications of this procedure. Firstly is infections, then hematoma, arterial punctures, and also fistula, pseudoaneurysm, and catheter embolism. All these complications can be prevented by doing this: reducing numbers of attempts, apply the pressure, apply sterile dressings, reduce manipulations, assess line under the sterile conditions, and remove the line promptly. Okay, I think that's all from me. I'm so sorry I cannot provide the video, but in this slide, but I have sent the video at our group. Okay, thank you.
Okay, any questions? Tak ada. So what's the difference, Alif,
Okay,
between your procedure ini central line dengan peripheral line yang tadi yang Hidayatul tadi?
Okay, firstly, what difference from the central IV line that presented by Aliyah? First, IV line is superficial, and then for the central, usually deep under the skin, and then IV line involves small veins, and then for the central line involve large vein.
And then di teknik procedures sama ke?
Teknik difference.
Okay. Apa yang beza?
Teknik, we introduce the catheter. For IV line, we use the needle, and then
semua IV lah kan, your line pun
semua IV
tapi central kan, central dan peripheral. Kalau central kan kena salah dengar teknik tadi, ada apa introducer tadi kan. Okay, satu wire. Okay, lagi satu apa yang untuk preparation tadi? Yang penting tadi gambar ada kan clear. The operator kena macam mana?
In sterile condition.
Okay, macam OT punya procedures kan, kena pakai PPE level 2 or level 3 kan. Kalau peripheral only apa namanya?
Apron.
Clean apron and clean glove pun tak apa, tapi kalau central kena sterile glove. And all the apa namanya area pun kena sterile. Patients pun apa? Kalau tadi kan yang peripheral only apa sekali swab je kan. Kalau ni kalau use kena buat double technique, not only alcohol tapi first using betadine kan, povidone iodine or sometimes chlorhexidine.
Chlorhexidine.
And then area yang tepi-tepi kena tutup with sterile kainnya yang sterile. Okay, and then difference tu tadi kan di purpose kan. Purpose-nya actually some medication need central line. Apa je, tahu tak? Kalau macam you bagi IV fluid kan peripheral line boleh tadi Dayatul. Bagi dextrose ke bagi normal line boleh. Tapi kalau yang kena central line apa? Tak tahu.
Kemoterapi.
Oke, kemoterapi. Balik lagi fluid pun kalau yang isotonic or osmolar solution peripheral tak apa. Tapi kalau hyperosmolar contoh dextrose sampai 10% boleh peripheral. Tapi kalau in neonates kita sometimes need dextrose 12.5, sometimes need dextrose 15%. So must use central line ya, because kalau peripheral line hyperosmolar apa complication dia? Ya thrombophlebitis lah. Ya jadi jadi bengkak lah kat tepi tu. Okay. And then drug tadi ya, kemoterapi. Dan for research tu, some inotropes tu better using central line. What more yang vasoconstrictor. Contoh kalau you obat vasoconstrictor? Tak tahu. Kalau kita pakai epinephrine or norepinephrine, kalau you letak perifer, ya kecut lah di vascular tu. So kena insert tu central line. Okay. Antibiotik pun actually peripheral okay, tapi sama antibiotik tu dia high high concentration. So kalau letak peripheral easily tissue lah, easily dia phlebitis ya. Okay. Alright. Thanks. Next.
Assalamualaikum warahmatullahi wabarakatuh. My name is
Waalaikumsalam.
binti Muhammad Zaidan. First of all, I would like to seek for forgiveness sebab I'm currently servicing my car. Kalau bising tu, I'm so sorry.
Kenapa? Tak dengar?
Tengah servis kereta.
Oh. Itulah nampak bising sangat. Alright.
Oh, bising sangat. Okay, I'm so sorry. Next. Okay, so first, we have to know the indication and contraindication for doing blood culture to a patient. So the indication for us doing blood culture is that because we want to know what is the etiology of organism that cause the patient to have pyrexia or fever. So usually we want to know so that we can manage the patient differently. And also if there is any suspicion of infective endocarditis so that we can know the etiology, to know for unexplained leukocytosis or leukopenia, or if the patient presented to us with clinical features of sepsis such as tachycardia, tachypnea and hypotension, and also for systemic and localized infection. Basically because we want to know what is the etiology that cause patient to present with such presentations such as fever. And contraindication, it is just the same as like venipuncture. Possible, we have to avoid from injecting at the site with extremities of broken bone or if that site is swelling or having edema, compartment syndrome, open wound, broken skin, or if there is any bruise, or if the site is erythematous, or if there is any filtration or arteriovenous fistula. Basically, it is just the same as the previous presenters have presented. Next. Okay, so before we want to do blood culture to a patient, we have to introduce ourselves to the patient, including the name and also whether we are medical student or HO or any doctor. And then we also have to confirm the patient's name and their date of birth, and we have to explain what kind of procedure that we will do to them so that they will understand what we actually doing to them. And then we have to gain their consent to proceed with the blood culture and ask them if they have any allergies, such as allergies towards latex. And then we also have to expose adequately the patient's arm for the procedure. Usually blood culture we do at the arm just the same as venipuncture, usually at the antecubital fossa. And then we also will position the patient so that they are sitting comfortably and ask the patient whether they have any pain before we continue the procedure. And then we also have to wash our hands using alcohol gel, and also gather and prepare equipment as well as doing apron and also sterile gloves, because this one it is actually a sterile procedure just like macam dalam OSCE. So we don't want the blood that we have collected to be contaminated with other agents, with the environment agent. So if possible, we have to make sure that surrounding is comfortable. And then if possible, we also have to shut off the fan so that the surrounding microorganisms will not interfere the blood that we have taken for blood culture. Next. So the equipment that we need are we need apron, sterile gloves, tourniquet, blood sampling devices. Like in this picture, they have a blood sampling device like macam cylinder punya. But then for Malaysia, like what I've observed the HO previously done, they just take like IV like venipuncture, whereby they have syringe and also needle. So usually the syringe that they will use is 20 cc syringe, because there are 2 blood culture bottles that we have to fill with 10 cc each. Okay, and then we have blood culture bottle and also the cleaning swab, 2% chlorhexidine and 70% isopropyl alcohol. Okay. And then we have sterile gauze, sterile plaster, tape, laboratory form, and also sharp container. So here we have to bear in mind that this is a sterile procedure. So we have to don the apron, and also we have to shut off the fan, and also we have to make sure the area that we want to take the blood from is clean from any infection. Next. Okay, so first that is the blood collection device, and then we also have to clean the blood culture bottle. There are 2 blood culture bottles which are blue and also purple for aerobic and also anaerobic bottles. And we will clean the blood culture bottle also using the 2% chlorhexidine. They're also using the cleaning swab, whereby we also will clean the site of injection at the patient. Okay, next. Okay, next, after we have gained their consent and then we have gathered all the equipment, we have to choose the arm. And also bear in mind about the contraindications that I have listed earlier. And then we can also place a pillow under it so that the patient will be more comfortable. And also we have to choose the vein, inspect the patient's arm to look for appropriate venous puncture site to see if the site is not erythematous or bruised. And also apply the tourniquet, if possible, 4 to 5 finger width above the planned venipuncture site. And like what I've mentioned, usually we will inject at the antecubital fossa. Palpate the veins if you are unsure. And then once you have identified the suitable vein, we can start taking blood from there. And then here also we have to clean the site using 2% chlorhexidine in circular manner from inner circle to outer circle, and if possible minimum 3 times, because we want to make sure that the area is clean. Next. Okay, so here, like what I've mentioned, apply the tourniquet 4 to 5 feet finger width above the planned vena puncture site, and then we have to inspect to look for the median cubital vein, and then by asking the patient to clench their feet so that we are able to visualize the site of injection. Don't apron, wash hands, and also don't glove, and also clean in circular motion from inside to outside. And also, like what I've seen in our hospital setting, usually they will drape like a sterile paper around that area so that we can minimize infection, and also so that the blood that we take is really the pure blood that we want. We do not want it to be contaminated with other agents. Next. Okay, so we need to insert the needle just like previous injection, which is less than 30 degrees angle. And then, okay, next. Okay, we have to insert the needle and observe for flashback. This is in their hospital setting, whereby they have the blood sampling device. But then for Malaysia, we can take the blood by using 20-50 syringe at a 30-degree angle or lesser than that. Okay, next. Okay, so this one, they will do it manually, whereby they will insert the first bottle into the blood sampling device and take the blood, and also insert another bottle. However, in Malaysia setting, after they have taken the blood in the 20 cc syringe, they will put the blood. They will insert the blood into the blood culture bottle separately. And then after that, we will release the tourniquet and apply pressure with the gauze once needle has been removed, and then we will discard all the devices, all the needle to prevent shock, sharp prick. Next. Okay, and then after we have done the procedure, we will explain to the patient that the procedure is now done. And then they should say to us if the vena puncture site becomes painful or inflamed. Thank them, wash their hands, and also do not forget to label the blood culture bottle with your name. Okay, yeah, that's all for blood culture devices. For blood culture and sensitivity. So what makes it different is that it is a sterile procedure. So we have to make sure that everything that we do is in a sterile way. And also there is 2 blood culture bottle, which is purple and also blue for aerobic and anaerobic, so that we are able to know what is the etiology that causes the patient to have fever. Yeah, that's all for blood culture.
Alright, so what's the difference?
Difference is that this is a sterile procedure.
Yeah, sterile like central line, but the PPE is level 1 only apron tak apa. Kalau yang tadi kan yang central line kan need level 2 or level 3, need yang even gown pun kena sterile ya. Yang blood CNS ni only the glove yang sterile ya. Okay, any questions?
Sarah, nak tanya boleh?
Yes.
Selain media cubital vein tu, ada tempat lain ke boleh macam possible untuk blood CNS ni? Ke tu je?
I think dekat tempat lain pun boleh juga, but then mostly I saw the doctors they will take from that area because actually the amount of blood that we need to take for blood culture is quite a lot. So the easiest access is at the antecubital fossa.
Okay, thank you.
Actually similar lah with apa namanya?
Puncture.
With IV line, with vein puncture, sama je as long as you get the good flow from the device tu, so you can get the adequate amount of the blood. And then sama juga kalau you nak sekalikan dengan pakai IV line insertion using granula pun should be okay. But we don't drop lah because it is blood culture kan, we need to shrink out kan. So granula tu after inserted the catheter, so you letak syring kat situ and then pull out. So you collect the blood to the syring and then after that you enter the blood to the blood CNS bottle. Ada tak bottle tadi? Siapa presenter ni? Lupa saya. Sarah.
Sarah, yes.
Color apa bottle dia?
Yes.
Bottle 40 tu. Yang ini untuk misalnya kan our current practice using Paktek punya company ini kan punya blood CNS sampling bottle. Color ni kan ada dua tu, ada biru, ada purple. Tapi itu bukan untuk pediatrics ya. Yang untuk kids color apa? Biasa kita pakai yellow untuk pediatric aerobic blood culture. Itu yang color biru dengan purple itu apa beza? Tak tahu.
I'm not sure, doctor.
So sama ya, nanti you googling apa beza the colors of the bottle tu. Dia different color, dia different purpose. Okay, next jumpa saya tanya ya. Okay, right. Any other questions? Okay, thanks. Next.
Assalamualaikum. Can you just hear me? Hello.
Perlahan.
Dengar tak? Ini dengar tak?
Better.
Okay. Okay, Assalamualaikum. I'm going to present about the orogastric tube insertion. So for my name is Nur Fazil Zinira binti Fazil. Okay, so next. So here's my outline for the OGT. Next. So the definition of the orogastric tube insertion is it involves the placement of a tube into the stomach via the oropharynx to facilitate the gastric suctioning and or decompression. Next. So indications for the OGT is for the administration of the nutrition or feeding, medication, and also the evacuation of the stomach contents. Next. So the contraindications for the OGT is if the patient is in the post-operative period. And then next, if the patient had been known with the structural abnormality, for example like choanal atresia where there is a block at the nasal passage. Then if the patient had recent caustic congestion, which the patient ingests a strong acid or alkali that can cause injury or burn to the upper GIT. And then if the patient is suspected with the spinal injury, because if we still insert, it might be misplaced into the spinal canal. Then if the patient is known or suspected with the esophageal varices, CLD or liver failure. If there is upper gastrointestinal stricture or obstruction, if the patient is suspected with nasal, maxillary, oropharyngeal or esophageal trauma, and suspected base of skull fracture and also the bleeding disorder. Next. So the risk that the patient can get is the pneumonitis from the gastric fits that being deposited into the lungs. Then the intracranial insertion if the child had skull fracture, aspiration, trauma, pneumothorax, and also the spontaneous passage through the pylorus that can lead to the feeding intolerance, abdominal pain, and also the poor absorption of the medication and also diarrhea. Next. So here's the equipment for the OGT, which we need the PPE, OG tube, water soluble lubricant, oral syringe, stethoscope, permanent marker or tape, suction, and also the pH strip. Next. So for the procedure, so for the preparation, before we inserting the tube, we must ensure the vital signs, oxygenation, and also the ventilation monitoring. And then we must put the patient in the supine position. So means that the head of the patient should be flat and or preferably elevated as the child condition permits. And if indicated, we can have assistant or maybe a second person to keep the child immobile or the presence of the parents for the spot. Then do the measuring. For the measure, I will show at the next slide. And then lubricate the distal tip of the tube with a water-soluble lubricant. Next. So this is how we want to measure the OG tube or how much length that we need to insert into the patient. So we can measure it from the tip of the nose to the bottom of the earlobe and then to the halfway between the xiphoid process and umbilicus. So the way we can remember it by NEMO, nose, ear, and umbilicus. Next. So to insert the tube, we must thread the tube through the mouth gently but steadily. So we should avoid extending the head backward. And if there is a cervical spine injury, we shouldn't flex the child's head. If the passage is difficult or the patient had developed symptoms such as choking, coughing, cyanosis, so we should remove the tube and replace at a different angle. Next. So we put the end of the tube downward and insert the tube into the oral cavity over the tongue. We must aim the tube back and down toward the pharynx. And when the tube touches the pharynx, we flex the head forward so that the tube will insert into the esophagus, not the trachea. And if the child is cooperative, we can ask the child to take sips of water through a straw while the tube is advanced. Next. Okay, after we inserting the tube, we must stabilize the tube by tapping it circularly on the face. We should avoid tape directly on the neck or to the nose because we don't want any block for the patient to breathe. And ensure that, sorry, I forgot. After we measure for the tube, we should mark the point at the tube where it's supposed to be end or exit the mouth. Okay, so when after we put, we stabilize the tube, so we ensure that the mark that we put on the tube is visible where the tube exits the mouth. Okay, so to verify the placement, we can do the swoosh test, which we attach the string and we flush the air while auscultate the stomach for the swoosh or bird sound. We also can do the pH measurement, which we aspirate the fluid from stomach and apply to the pH strip and make sure that the pH should be less than 6. So for the verification, in the high-risk patient, for example, if the patient has neurologically impaired, absent of the gag reflex or critically ill, so we need to confirm it by the chest X-ray for the placement of the tube, either it is in the correct position or not. So the tube should be below the diaphragm. And then in the low-risk patient, the pH measurement must be less than 6. So if it is more than 6, we must confirm it by the X-ray, or we remove the tube and replace it back. And for all patients, we must monitor for the signs of the respiratory distress, For example, like cyanosis, dyspnea and coughing, pH measurement, and ensure that there is a mark at the exit point of tube. For the OG tube removal, first we should turn off the suction or continuous feeding, put the patient in the supine position, and elevate the head of the bed as tolerated by the child. And if indicated, we can ask assistance so that we can keep the child immobile, or parents present for the support. Then gently remove the tape from the face by using the adhesive remover or saline wipe. Occlude the tube by pinching it close, bending it, and holding it with the thumb and index finger. Then we pull the tube out of the mouth using a swift and also consistent motion. Next. Okay, so basically the orogastric tube and also the nasogastric tube procedure are the same, including the indication, contraindication, and others. But for the pediatric group, so in the OGT, we use in the newborns and also the young infants who obligate nose breather. If since they are nose breather, if we insert the nasogastric tube, it can cause partial nasal obstruction that can increase the area resistance and also the work of the breathing. And then the OGT also is used in the older child who are intubated, unconscious, or unresponsive. For the nasogastric, it is used in the infants and also the children for feeding when the child is comatose, semi-conscious, or unable to consume sufficient food. Sorry, if not blood, consume sufficient food. So that's all from me.
Sorry. Hello. Sorry, tadi masih so yang question kenapa nih apa ada ini kah? You pakai dua ke apa?
Ya.
Suara saya tak clear lah.
Clear.
Clear ya? Okay.
Clear.
So tanya yang masa NGT ni, koma tu nak kalau pasien conscious koma nak pakai OGT ke NGT?
Sorry, doktor.
Sorry, Fazal boleh tolong mute? Okay.
Okay, kalau apa? Kalau patient unconscious koma ni pakai OGT ke NGT? Yang koma ni. Koma ini is
If patient coma,
sorry?
I think for if the patient is coma, can be used both OGT or NGT, but OGT is in the older child who are coma. Meanwhile, NGT is in infant who coma.
Salah. Actually, kalau yang OGT itu kalau patient still alert or semi conscious, kalau patient apa koma tu pasang OGT lah. Yang tu dah ada, yang sebelah kiri dah betul, yang sebelah kanan tu yang not proper. Okay, actually which one is most physiologic, OGT ke NGT?
NGT.
So orogastric is more physiologic. The problem lah kalau in older children, kalau dia alert, coba mute dulu. Nah, in older children tuh kalau dia boleh mute dulu tak? Oke, in older children tuh kalau dia apa alert or semi conscious, if we put OGT dia akan apa tarik-tarik yang gigi apa not comfortable lah. Tapi kalau dia unconscious, koma, ya kita put OGT should be okay. Nah, in Indonesia OGT is obligatory ya. Another issue kan because tak ada gigi tuh in Indonesia kan, kalau in older children ada gigi dia akan gigit-gigit. Kalau dia apa still alert, kalau patient koma kita akan gigit lah. Tuh ya. Alright. Okay, thanks. Next.
So next we proceed with nebulization. So my name is Maya Shazana Shamri binti Ayazi. So next. So first, what is nebulization? So nebulization is actually a therapy or a method that delivers respiratory drugs directly to the lungs. So don't confuse what is nebulization and also nebulizer. So nebulizer is actually the device itself that convert the liquid solution or suspension into aerosol droplets suitable for the patient inhalation. So next. So this is the common medications that usually being prescribed through nebulization. So such as we have bronchodilator, which is salbutamol for indications of maybe acute exacerbation bronchial asthma or AECOPD, or also for severe asthma. So we also have corticosteroid such as beclomethasone for severe asthma. This usually being used at home because corticosteroid is for a long-term or preventive way for severe asthma. We also have anticholinergic such as ipratropium bromide, also use the same indication for bronchodilator. We also have antibiotics such as streptomycin, colistin, and aztreonam for chronic purulent chest infection. Next. So these are among the components of nebulizer, which includes the machine, the hose, the medicine cup, and also the delivery system, which we have the mask and also the mouthpiece. So the mask we have variety of size, so choose according to the patients. So next, what is the difference between the mouthpiece and also the mask? So for mouthpiece, there is no leakage of nebula solutions to the environment because the solution is directly entering into the mouth and into the respiratory tract. But for mask, there is a presence of leakage of nebula solutions to the environment due to because some masks have holes on it, so it could leakage to the surrounding. So for mouthpiece, there is no deposition in nasal passage or face because it, as I've mentioned before, because it directly entering into the mouth and also the respiratory tract. But for the mask, the solution can be deposited on the face and also the nasal passage because the mask is actually covering the nose and the mouth, and then the patient will be breathing through it. But for the mask, it is much easier for patient to use. Okay, so next, we will be watching this video on the steps in using this nebulizer. Kita lagi.
Delivery of medication via nebulizers by Craig Smallwood.
Before we proceed, we'll also want to ensure that the patient is in the correct position. I'm going to put the head of the bed to approximately 30 to 45 degrees. An important performance note about jet nebulizers is that they should be oriented approximately vertically to work effectively. Tilting the device too far, perhaps 20 to 30 degrees on any angle, in any direction, can cause the medication to move away from the jet gas port inside the device and render the treatment ineffective. If you notice the treatment you are administering is taking a long period of time, or there doesn't appear to be an appropriate volume of aerosol generated, you may want to check the nebulizer to ensure proper vertical orientation. Next, I'm going to connect the nebulizer to our gas source using oxygen tubing. It should be noted that in order to adequately power jet nebulizers, a specific gas flow is required for this device. The manufacturer in this case recommends 9 liters per minute. However, it doesn't necessarily matter what type of gas. It could be 100% O2, air, heliox, etc. You'll need to exercise good clinical judgment to determine the appropriate gas for your treatment. Often, patients receive 100% oxygen if there are no contraindications, simply because this is the most readily available compressed gas in most institutions. But importantly, make sure that the gas flow is not running when you connect it. You should wait until the setup is complete and the device is adequately fixed to the child before you start the gas flow. This will minimize the amount of wasted drug and maximize the received dose. Next, I have our drug. I've removed the cap, and I'm going to take our medication, which is in a liquid suspension, and place it inside the device. We're going to replace the cap, attach the interface, affix the oxygen tubing to the bottom portion of the nebulizer, and place the mask on our patient. I'm going to turn the oxygen flow rate onto 9 liters per minute as per recommendations by the manufacturer. This treatment should last anywhere from 10 to 20 minutes.
Okay. Okay. We have watched the video on how to use the nebulizer, but the video doesn't state that before the procedure we need to same as the other procedure, that we also need to wash our hands. The universal precautions. So also in hospital settings, what I've been observed before, we usually use the oxygen flow rate of 3 liter per minute instead of 9 liter per minute. But yeah, we should use it according to the manufacturer exactly. So next. So what is actually the side effects of nebulization? So actually the side effects is not coming from the nebulizations, but the side effects is actually coming from the medication that have been prescribed through the nebulizations. So if the patient is having salbutamol inhalations, so the patient might have palpitation, anxiety, mild tremor, hypertension, dryness of the mouth, and headache. But for patients of anticholinergic inhalations, the patient might have blurred vision, elevated intraocular pressure, acute or worsening narrow angle glaucoma or cataracts. So basically, anticholinergic inhalations have side effects on the eyes. So that's why with patients that would need anticholinergic inhalation, we suggest for mouthpiece instead of mask, because because mask we have the leakage to the surrounding, and then the leakage of the solution of the mist would go straight up and then goes to the eyes. So that's why we prefer mouthpiece instead of mask in anticholinergic inhalation. So also we have a paradoxical bronchospasm, which is an unexpected constriction of smooth muscle wall of bronchi that occurs in setting of expected bronchodilatory response. So in short, the patients that receive nebulization should have an improve. The symptoms will be improved, but then but in this kind of patients, the symptoms is worsening. So we should discontinue the nebulizer immediately, and then give the other treatment. So that's all from me.
Okay, questions? Tak ada? Right, so kalau in children, you nak pakai mouthpiece ke nak pakai mask?
Kita pakai mask.
Because more difficult in children tu.
Yes.
You should use mask. And then is it only for medication, or can we give non-medication? I mean, not any drugs maybe. Despite drugs, nak bagi apa lagi?
Could we give normal saline?
Normal saline is much safer lah. The safest way use the normal saline lah. So, did you observe in the ward? Usually they use pure dissolution from the drugs, or combined with saline.
Usually combined with normal saline.
Why? Any idea? Nak combine berapa mil biasa?
I'm not sure, but I've attached at emergency before, and then they use 2 liters. Sorry, 2 ml of salbutamol with 2 ml of normal saline.
So 1 to 1 kan? Jadi common common combinationnya 1 to 1 ya? So kenapa tak tanya?
No.
Actually, it's more on the effectivity of the aerosol generating tadi, the foremost yang jet nebulizer loh, dia kan will give high pressure from the machine or from the oxygen or air source. They need adequate volume lah to produce adequate aerosol. So, kalau you only use the drugs only 2 mil, usually dia tak cukup. Usually we add on lah at least 3 mils lah. So kalau 1 to 1 kan, so 2 plus 2 maknanya 4 mils lah. So it will be adequate. But in case you're very cooperative, we can make very vertical position of the airport jet port. So boleh je only 2 mils akan keluar juga, tapi usually very fast lah akan habis. Kalau patient tak kooperatif ya cepat habis, tapi dia tak sempat hirup, susah. Usually we give more fluid supaya dia sampai 15-30 minutes ya. Okay. Tapi let's say sometimes even in small child kan, the dose is only 1 ampule, but in children more than 6 years old, sometimes you can give 2 ampules of salbutamol tuh. 2 ampules ya you get 4 to 5 cc kan. 4 to 5 mils. Nah, kalau udah dapat 5 mils ya no need to no need to add on or combine with normal. Okay. Alright.
Okay, Bismillahirrahmanirrahim. Next, I will proceed with Lamba Puncture. My name is Abdul Hazim bin Muhammad. Okay, next slide. So, Lamba Puncture is one of the most common and important procedure that done in clinical settings. So, Lamba Puncture can be indicated for both diagnostic and also therapeutic purposes. Lamba puncture can also be used to administer spinal and epidural anesthesia, and for diagnostic purposes, the CSF can be used to diagnose infectious disease such as meningitis, encephalitis, and also myelitis, and also inflammatory disease such as multiple sclerosis and Guillain-Barré syndrome, cancers such as leukemia, and also metabolic disease. And for therapeutic purposes, the lumbar puncture can be used to administer chemotherapeutic agent and also antibiotics. Okay, next. So for the contraindications, lumbar puncture is contraindicated when there is presence of infection at the sites of the puncture, and also with patients with signs of raised intracranial pressure, because it can increase the risk of cerebral herniation. So in this patient, we should perform CT scan of the brain before we do lumbar puncture. And other contraindications are severe thrombocytopenia and uncorrected bleeding disorders. And lastly, the presence of cerebral mass lesions such as abscess or tumors. Next. So this is the equipments that are needed for performing lumbar puncture. The first one is spinal needle with stylet. This spinal needle can be vary in the length, ranging from 1.5 inches for infant, 2.5 inches for child, and 3.5 inches for adult. And then the sterile gloves, skin prep and drapes, collection tubes for the cerebrospinal fluid, and also manometer in some cases. Next. So for the positioning of the patient in lumbar puncture, it can be divided into lateral recumbent and also sitting. But the most preferred position is lateral recumbent. So in this position, the head prop up on a single pillow to keep the spine straight, and the knees and torso is flexed to optimize the interlaminar foramen of the vertebrae. And for sitting position, it can be useful in patients with potential airway compromise. And the trunk is flexed by having the patient lean forward and rest the elbows on the table or on their knees. And for the injection, for the puncture site, we can mark out the L4 level by joining an imaginary line between the superior aspect of the iliac crest as shown in the picture, and then the spinal cord ends at the level between L1 and L2. So basically, we have to insert the needle much lower. So the level of insertion usually at the level between L3 and L4 or L4 and L5. Okay, next. So for the preparation, so as for any other procedure, we should also introduce ourselves and confirm the patient's information, explain the details of the procedure to the patient, and also gain the consent. And then we should clean the insertion site and surrounding area using chlorhexidine solution, and wash your hands and don sterile gloves. And we should apply a sterile drape over the puncture site with an opening over the puncture site. And also we should inject local anesthesia around the site and allow time for it to take effect, at least a few minutes. Next. So for the procedure, we should advance the needle slowly, and the needle should be tilted slightly cranially at an angle approximately 15 degrees, as if we are aiming for the patient's umbilicus. So if positioned properly, the needle should pass all these layers before it reach the subarachnoid space. The skin, the subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, posterior epidural space, and also the dura. And as the needle passes through the ligamentum flavum and bridge the dura, you can feel a popping sensation, because that indicates a decrease in the resistance, and usually the CSF should begin to flow at this time. Next. So for to measure the opening pressure, it should be done in patient with lateral recumbent position only, by attaching a manometer by using a flexible tube. However, this measure the opening pressure usually not need to be performed routinely. And if the opening pressure exceeds 25 centimeter of the water of the water level, we should closely monitor the patient for the risk of cerebral herniation. Then for the sample collection, we should collect the sample by using aseptic non-touch technique as it drips from the back of the lumbar puncture needle. And lastly, we have to slowly remove the needle and place the bandage over the needle insertion site and immediately dispose of the lumbar puncture needle into the sharp beams. Okay. For the video of the procedure, I provide the link for the video at the end of the slide. Okay, next. So for the complications, lumbar puncture can cause herniation, local or referred pain, post-puncture headache, bleeding, infection, and also CSF leakage. Most of these complications we can avoid it by performing neurological examination before performing the lumbar puncture and also monitoring the patient throughout the procedure. Okay, that's all from me. Thank you.
Okay, question? Tak ada juga. So apa? Position, Hazim. Position of the patient tu flexion ke extension?
Flexion. The
Okay.
patient need to flex. It's
So increase the space tu.
the space between the vertebrae.
Is sempit sangat, very narrow space ya. And then kenapa tadi kena L3 or L4 tadi? Why?
Because the spinal cords end at the level between L1 and L2, so we need to puncture at much lower level to avoid injury to the spinal cord.
Okay. So contraindication?
Contraindication can be the patient with signs of increased intracranial pressure because it can cause herniation and also apa?
Contoh apa? Increase ICP apa yang you boleh observe?
From the examination we can see if the patient has papilloedema and focal neurologic signs.
Focal depend lah actually. Focal neurologic sign sign of the upper motor neuron lesion kan, but not necessarily increase ICP. Okay, anything else? Contraindication lagi satu.
Thrombocytopenia.
Okay, alright.
It can cause bleeding.
Lagi satu. If it is suspected bleeding, sorry, is suspected apa nama? Yang cause bleeding itu not only thrombocytopenia, kalau dia ada prolonged coagulation ya. Kalau coagulation profile prolong ya jangan. Dan lagi satu yang if it is suspected hemorrhagic CSF ni apa nama? Case of intraventricular bleeding is contraindicated. Usually patient ventricular hemorrhage tu IVH tu ya sama dia prolonged coagulation and then anemia ya. Okay. Alright. Anything else? Udah, thanks. Next. Berapa lagi nih? Satu lagi, dua kan? Satu lagi. Another two. Okay. Alright.
My name is Aisha regarding urinary catheterization. Next slide. So what is urinary catheter? Urinary catheter is a tube placed in the body to drain and collect urine from the bladder. Next slide. There are two methods to place the urinary catheter, either urethral or suprapubic. From urethral, there are indwelling catheter, intermittent catheter, and also external catheter. Next slide. Okay, next slide. So indwelling catheter is also known as Foley catheter. It is passes through the urethra and into the bladder to drain the urine. The indications is to for acute irritation after surgery, anesthesia, or nerve injury, and also to relieve acute bladder outlet obstruction due to severe prostate enlargement, blood clots, or urethral compression. Need for accurate measurements of urinary output in critically ill patient, and patient will require strict prolonged immobilization. Next slide. So these are previous slide. Okay. So these are Foley catheter, double lumen. We initially for Foley catheter we have double lumen and also triple lumen. Unfortunately, I didn't put my slide step by step, so I will briefly mention the step here. To place a urinary catheter in a patient, first of all, we must prepare the patient by explaining the reason for the procedure to the patient or to the family in case because we are in the pediatric group. And then we have to explain the step of the procedure to patient or family and check if the patient has any allergy to latex. Because this catheter is made of latex. And next we have the catheter equipment, which is the urinary catheterization kit. And then we have to ensure the privacy of the patient. We have to cover patient's cubicle and pull the curtains. And next we have to perform the hand hygiene. And then before placing the catheter, first of all we have to check for the size and type of catheter. Because we are in pediatric ward, there are different types of catheter with different diameter. In catheter, the diameter is called French. There are many sizes of catheter, and the color code determines the size of the catheter. One French is equal to 0.30 millimeter. So, for example, for patient less than 2 years old, we use urinary catheter with the size of 5 French scale. So after we pick the size of the catheter, before placing the catheter, we have to place the waterproof pad under the patient and position patient in supine position. For male, we have to extend the leg and slightly move apart the leg, and for female, we have to flex the knees and relax the thigh so that the hips rotate to expose the perineal area. And then after that, we have to apply the sterile glove and attach the urinary bag to the bed and ensure that the clamp is closed. And then we have to drape the patient with the drape found in catheterization kit and lubricate the tip of the catheter using sterile lubricant. And then we have to check the balloon inflation using sterile syringe and pick up the catheter with right hand, with dominant hand. If the person doing the CBD is left-handed, so he need to pick up the catheter using left hand. And then we have to slowly inflate the balloon syringe and connect the urinary bag to catheter using sterile technique. Then after we finish performing the procedure, we have to remove the glove and do the hand hygiene. Next slide. So these are contraindications if the patient has traumatic injury to the lower urinary tract, and complications of Foley catheter is allergic reaction because the catheter is made of latex, injury to urethra, kidney damage, and septicemia due to infection of the urinary tract, kidneys, or blood. Next slide. So this is short-term catheter. For folic catheter, we place it for longer term, but short-term catheter, we only put it to collect the urine. For example, if you want to collect the urine for specimen to send for urinalysis in case if the patient is suspected for UTI. Next slide. This is a conscious use fireman with no urinary problem but has serious functional or mental disabilities. Next slide. So just now I mentioned that for suprapubic, it requires surgical placement through the abdominal wall and into the bladder to drain the urine. When we use a suprapubic catheter, when it is contraindicated or technically not possible to relieve urinary retention due to urethral obstruction, BPH, or prostate cancer. So these are contraindication for suprapubic catheter, coagulopathy, and if the patient has history of lower abdominal or pelvic surgery. And among the complications of suprapubic catheter are infection, bleeding, catheter blockage. It also can cause bowel perforation and also bladder perforation. That's all from my.
Okay, so size tadi kalau tadi yang size 5 tadi untuk umur berapa? How old?
Less than 2 years old.
Apa putus-putus ni siapa? Arisha. Pur connection ni jadi Arisha ni. Berapa kalau size 5 umur berapa?
Less than 2 years old.
Less than 2 years. Ini kalau older size berapa? Kalau dia lagi besar.
There is size 6, 8, 10, 12.
Bukan itu dah ada belum? Yang ada berapa bisa size? 12 ya.
Green colored 6, blue colored 8.
Itulah biasanya.
White colored.
Tidak, dia biasa pakai size berapa? Biasa pakai 8 kan kalau sana. Ke yang lagi besar? Tak tahu. Okey lah, mana? Okay, thanks Last. Last but not least.
Alright, can you hear me?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh. I am Ifamawada binti Suhaimi and I would like to present about technique to use metered dose inhaler with spacer. Okay, next. I'm sure all of you know that inhaler is a portable device for administering a drug which is to be breathed in into the lung. So it is commonly used for treatment of asthma and other bronchial or nasal congestion. For treatment of asthma, there are two types of medication used for asthma inhaler, which are reliever inhaler and controlled inhaler. For reliever inhaler, it contains bronchodilator medicine such as salbutamol and terbutaline. And usually, these inhalers are often blue in color. Right. For controlled inhaler, usually contains steroid medicine such as dexamethasone, and usually this type of inhaler often brown or red in color. Right. 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 These are several types of inhaler device, and these are the main type of inhaler. Right. The first one is pressurized metered dose inhaler, MDI. This is the standard MDI and most widely used. It contains pressurized inactive gas that propels a dose of medicine in each puff. So each dose is released by pressing the top of the inhaler. This type of inhaler is quick to use, small and convenient to carry, but it needs good coordination to press the canister and breathe in fully at the same time. Right, next, another previous slide. For breath activated inhalers, it is alternative to standard MDI. Some breath activated inhalers are also called dry powder inhalers, where these inhalers do not contain pressurized inactive gas to propel medicine. So the patient does not have to push the canister to release a dose. Instead, just trigger a dose by breathing in through the mouthpiece. Then the last one is inhaler with spacer device. Basically, it is just the normal inhaler attached with spacer device at the center. Next. The spacer device are used to improve drug deposition in the lungs and also useful for reducing the side effect of high-dose inhaled corticosteroid by decreasing the amount of drug deposited in the mouth. So these MDI with spacer are recommended for young children and babies because it does not require for the user to have good coordination when using MDI with spacer. Different with if using MDI alone, the patient need to press the canister and breathe in at the same time, but with the spacer, does not need to do that. So this inhaler also can be attached with face mask that suitable for children aged 0 to 6 years. Okay. Next, I will share on how to use MDI with spacer along with the video. So first one, remove the caps from spacer and metered dose inhaler. And then shake the MDI for 3 to 5 seconds before using it. And then spray the MDI. If using it for the first time. Sorry. These the steps like in the video. You can read it after this. But I want to highlight it that after use the MDI with spacer, need to rinse mouth with water or brush teeth to make sure to rinse and spit and do not swallow it. Yeah. And this is spacer device care instruction. A spacer device should be washed with detergent or liquid and that's fine once a month and left to air dry. Should never be wiped dry. This can cause static within the device and drug particles will stick to side of spacer. And spacer should be replaced at least once a year. Okay. And the last one is potential side effects. And the side effects, it comes from the medicine, such as palpitation and tremor, because salbutamol can cause tachycardia and tremor, particularly at high dose. And also oral thrush, because steroid inhalers can cause candidiasis, particularly if the patient does not wash their mouth effectively after each use. That's all from me.
Okay, ya. So kalau in children boleh tak hold breath for 10 second tadi?
No.
Tak boleh kan, especially yang apa below 5 below 7 years tu still tak boleh. So apa instruction kalau yang children?
Nafas macam biasa.
Berapa kali or berapa lama?
Not sure.
Sama lah, around 10 second tadi. 5 to 10 apa breath lah. Okay. So apa tadi difference between MDI and DPI kan? Kalau dry powder untuk macam mana?
Dry powder tak payah tekan.
Okay, and then sedut terus kan? So boleh tak pakai special?
Not sure.
Kita boleh lah. Yang DPI tu ya must direct apa namanya inhalation from the device. We cannot use aero chamber or other special itu. Itu tadi yang gambar video itu kan ini Philips ya. Kalau yang apa nama aero chamber itu color apa usually in children?
Blue.
What color ada how many color do you know?
Don't know gitu.
Mana Ifai? Senyap je.
Not sure Doctor.
In infant usually orange ya. The smallest is orange color for infant. But kalau dah above 1 or 2 years sampai school age tu boleh color yang yellow tu. Kalau adult color apa lupa ya. Blue ya kalau salah adult. The most common to be used ya yellow color tu. Even yang tadi yang this brand tu dia ada size infant dengan size pediatrics. Istilahnya kita pakai yang size pediatrics because asthma tu we start to give inhaler tu usually kan around 2 years old kan. Yang infant very early tu jarang sangat yang sebelum umur setahun ya. Okay, dah any more questions or?
Nak tanya boleh?
Alright.
Bahaya tak kalau orang normal macam tak ada masalah respiratory ni dia guna MDI? Sebab saya pernah guna, kawan saya punya pernah main.
And then what happened to you? Are you dead? Were you dead or still alive lah? Still alive. Ya, tadi kan ada side effect of the drugs tu usually related to the dose lah. Dose related side effect. Kalau you just accidentally use once, it's okay. Unless if you use it continuously, will be high dose, will be toxic. Alright. Okay, other questions maybe? Dah, tak ada? Okay, so tadi ada buka dengan Fatihah tadi, Hamilizat tadi?
Ada Doktor.
Okay, so we close with tasbih kifarat nasr ya. Okay, thank you all. So your assessment for the presentation dah dapat semua, alright. So next ya itulah maybe you don't have any case kan until today kan, any real case kan. Maybe itulah if I have time I will try to get from my patient, but at least nanti masa after next week you come to Kuantan, you have 2 weeks kan, to get face-to-face sessions kan. So hopefully within 2 weeks face-to-face session tu you have at least 1 patient per kandidatnya, per studentnya. So cari seorang satu and then we discuss together supaya semua boleh discuss other you can get apa namanya, something from from your college. So ada yang present pneumonia, ada yang present asma nantinya. Okay, thank you all. Alright, see you. Assalamualaikum.
Thank you,
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.